Time to check the mailbag. Ding. Andrea, you're the marketing expert.
I have done.
What should we do to make the mailbag episodes even catchier than they already are?
Ding dong, mail. Ding dong, the mail's here. Mail's here.
Remember back in the old days? You've got mail.
Mail.
Oh, yeah. There you go.
I love that.
Well, I love it when we get mail. And we get mail from people all over the world, which is crazy.
I love it.
So what do you say? Should we hop into our mailbag episode?
Yeah.
Yes.
All right, let's do it. This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. Great to see you two.
Hello.
All right, welcome to another edition of the Mailbag. Mailbag edition. We've got questions from all over the world, and really a great cross-section of questions. Some have kind of some intersections because a lot of this stuff is related, but let's just jump right in. And if you want to send us a question for Dr. Cooper, info@diabesityyinstitute.org. Is that right, Dr. Cooper?
That's correct. That's it.
All right. First one up is from Kate, Dr. Cooper. Hello. I was listening to the COVID episode, and it was recommended to send quotations here for the next episode. So Kate is curious, how is it possible to have so many symptoms of metabolic dysfunction, but pretty much all labs come out normal? What should one do? Also, is gut health connected with metabolic dysfunction? Kate, thank you for the question. What's your basic reaction to that, Dr. Cooper?
That's really two questions.
Yeah.
Yeah.
That is two questions. But thank you so much, Kate, for writing to us. And that happens. I hear that a lot, that people say everything is normal, or their biggest fear is that everything will come out normal when they feel like something's wrong. And when we say the word everything, what do we mean by everything is one question that I have. You know, how is it that all the labs come out normal? Well, all the labs that were run are normal, but I always tell our patients, as much as we check, we're not checking everything. And because we can't even check everything. There are not clinical tests for an awful lot of things that have to do with our metabolism, but luckily we are able to test quite a few things that can give you insight on the metabolism. So that would be one thing that I'm wondering is how extensive was the workup? And also, what are the symptoms? Because you were saying that you have so many symptoms of metabolic dysfunction. It would be great to know what those symptoms are. Are those related to appetite, seeming off balance? Is it related to body weight, seeming off balance? Is it related to menstrual cycle irregularity? How far does it go in terms of the sense of metabolic dysfunction? Do you sense that you're having blood sugar swings, or what's really going on? And so I think when doctors are trying to get to the bottom of something, one of the most valuable things that they have to go by is what the patient is reporting to them. It's not the fancy tests. I mean, those are very important, but the very most important information is what a patient notices about their own health that they can communicate, because that provides a lot of different clues. And so that would be the ideal thing, is to make sure that you're providing enough information to the provider, really detailed information about what you're noticing that feels off balance. And then the provider hopefully would be looking in those key areas with some objective testing that does include lab tests and physical exam findings and things. And so hopefully things could be uncovered. But if the labs that are being run are just including something like hemoglobin A1C and a fasting glucose and a basic lipid panel, you could miss a lot of things, because there's so much more to metabolism than just what will show up on those labs.
For example, like a thyroid issue or something like that. There could be lots of things that could make you feel off, right?
It could. And, often thyroid is checked because everyone sort of blames that first. But it's true. Thyroid levels are important. But blood sugar, we always talk about how we like to look at glucose and insulin levels fasting and after eating, because there are many patients where the fasting looks fine and you only see the dysfunction if you test after eating. But also testing some kind of unusual labs at times is important too. But some of the basics, especially in women, looking at the reproductive hormone pathway, looking at the cortisol pathway, looking at the detailed cholesterol levels, all of that's really important. But even beyond that, measuring things like that we've talked about on the podcast, that's less unusual, less common to measure, which would be leptin, adiponectin, and even going as far as looking at some of the famine signals from the brain, neuropeptide Y, even looking at ghrelin, which is a hunger hormone from the stomach. So there are always more tests that could be done to try to identify what's going on. But there is another little catchy thing, which has to do with something that I nicknamed diet fog, which means if you're a person who has dieted a lot, often you cannot see what the actual metabolic dysfunction really is until the person stops dieting. Because the dieting causes a lot of defense mechanisms that hide the actual metabolic dysfunction.
Well, Kate, thank you so much for the question. It sounds like Dr. Cooper, Kate should talk to her doctor and explain what doesn't feel right, and then just try to see what they can do about getting some labs that might be able to nail down exactly what that is. Kate also asked Dr. Cooper about gut health and if it's connected with metabolic dysfunction.
Well, gut health is so important, and we've talked a lot about the microbiome and how to keep it healthy in previous episodes. But it is very, very important. But also keep in mind that a lot of the metabolic hormones regulate our gut motility. And if there is dysfunction in that gut motility, that can throw our microbiome off also. Because if, say, we're rapidly dumping food through our stomach into our small intestine too quickly, that could lead to problems with fermentation and things in the small intestine, when instead of methodical transit from the stomach to the small intestine, which would potentially favor healthier bacterial environment there in the small intestine. So a lot of times people are diagnosed with things like SIBO, which is very catchy, and it's, in my opinion, it's way overdiagnosed. But I get that people are having trouble and they may have issues with bacteria, what's called bacterial overgrowth in the small intestine. SIBO stands for small intestinal bacterial overgrowth. It sounds like a huge collection of words there, but it refers to a dysfunctional bacterial growth in that small intestine where we absorb a lot of our nutrients. But I always think, well, what's the reason for it? Because the way that people approach it today is to cut out a bunch of foods that are just hard to tolerate, or throw people on super high power antibiotics to knock out all the bacteria in your gut. So neither one of those things seems to work really well, because it just comes back because you're not really addressing the cause. And so I think it is tied to metabolism, because in our own patients, we do see it improve with improving metabolic function. And part of that, I think, has to do with the control of the gut motility. Because if you think about GLP-1 medications, for example, they are known to what's called slow the motility from the stomach to the small intestine. But in some people that have too rapid motility, they may just end up making it more normal. And so I think restoring a lot of normal metabolic function makes our gut hormones work better, which makes our motility more normalized, which prevents this bacterial overgrowth in the small intestine. So that's my opinion. So I try to shy away from doing like major food treatment of those things and instead work on metabolic function.
Well, Kate, thank you so much. And it sounds like, if you're still having symptoms of something not being right, just get back with your doc, figure out what you can test for, and don't rest until you get some answers, because if something doesn't feel right, it's good to keep looking into it. Kate, thank you for that.
Here's a question from Jean. Dr. Cooper, I've been listening to your podcasts, which are very helpful. I tried to make an appointment with you, but because I live in New Jersey, I was unable. I'm suffering from insulin resistance and can't get help. Is there any way that you could see me, or do you have suggestions? I see a dietitian who's knowledgeable of metabolic issues, but it's not enough. Thank you for your time, Jane. Well, you can explain why you can't see it. It's a legal issue, but explain the why. I'm not a lawyer or a doctor, so I can't explain the reasons, but I know why. So.
Well, yeah, we can't really see patients that are outside the states that we're licensed in, and so that's what it comes down to. It has to do with each state has its own regulations, and each state says you can't, even if it's telemedicine, you cannot treat a patient in that state unless you have a license in that state. And
you have to take lots of tests to be a doctor or a lawyer in each state that you're in.
It's not so much the test, it's just like a licensing process, but it's very extensive and it's not practical, and most states don't really want you to have a license and not have a clinic in that state and things like that. But
that's why.
So it's all providers all over the country are limited in their practice to practice in the states that they're licensed in. And so it's where the patient's physical body is that matters, which always seems kind of crazy because we do telemedicine services. So people don't quite always follow that, but that is the way it is. So that's the problem.
That's the rules.
And Jane's wondering about insulin resistance. So if she's not in Washington State, Dr. Cooper, what's your best advice? She's back east. How does she get help? Where does she start?
So, one thing, and this is a common thread question that we get quite a bit, and I was thinking about it because I would love to have a network of providers across the country, across the world, that have a similar treatment approach or treatment philosophy. And I was thinking, well, what makes it so different? Because there are endocrinologists, there are people that are board certified in obesity medicine, like I am, and they're all over the country and more all the time. And so it's not that they're not qualified to see a patient, they are. But I think what people are looking for is that same approach that is what we consider non-diet approach, not focusing on your food is the cause, your exercise is the cause of your metabolic dysfunction, and that somehow you're going to solve all your metabolic problems by altering your diet and your exercise. We say that we're not trying to discount the importance of nutrition and exercise as components of our health. They are very powerful health tools, but they don't have the level of power to reverse metabolic dysfunction. So not on their own for the majority of people. So people need medical treatment. And so I think that's what separates a lot of providers, and that's what you want to look for, are providers that understand that metabolic dysfunction is a disease process that's not a lifestyle problem. Like Andrea, you have a slogan for this that you taught me, right?
What?
It's not a potato chip problem.
Right. It's not a potato chip problem. And I would say, even bigger than what you're saying, that you can tell after a lot of experience with many, many doctors and many different philosophies from doctors, because doctors actually do have philosophies. If you talk to a doctor and you go and see a doctor, you can tell pretty much in the first 10 minutes if that doctor is a match for you, because the doctor's going to basically say things that are going to tell you that it's your fault. And once you talk to that doctor and realize that the doctor is basically saying that everything that you're going to have to do is about you and that you did it and that it's your fault, either just listen with a half an ear and leave the appointment and go, okay, next. It's like you're at the deli and you're going to be like, okay, next, because that doctor's not for you. The reason that I think Mark and I have stuck with Dr. Cooper for so many years and realized that this is a marathon, not a sprint, is that she said it's not a marathon, it's a sprint. You didn't do this, this didn't happen in a day. It's not going to fix in a day. And it's not something that you did, and it's not something that just like miraculously is going to fix. It's not something that like we're going to give you a magic potion and tomorrow you're going to be, 50 pounds lighter or 50, whatever. It's a process. And it's also, it's something that you experiment with. It's something that you work with. And you want that partner. And the doctor is going to be like your partner in fixing it. And it is something that takes time. And it's not magic. And even though these drugs, I sometimes do over-exaggerate because that's me, and I go, oh my God, this is scientific magic. But it isn't really scientific magic. It is science, and I thank God for it every day. Like, I just am so thankful for it every day because it has changed my entire life with help. I mean, I couldn't have done it myself. That's what you want to look for, and you want to look for somebody who's compassionate and somebody who says, I want to help you. Not somebody who's like, I am the hell. Like, that's what you want.
Yeah, and I think, Dr. Cooper, you've encouraged us in the past to find that physician who's curious.
Right.
And who doesn't have maybe all the answers. And we've talked about this before, but, my family doc that I saw for years, Dr. Cooper, when I took the labs, when I first started seeing you, and I took my labs to him, and he was honest and said, I really don't know what she's doing. But if it's working, keep going.
Right.
And I thought that was amazing. And he was a guy just about to retire. He'd been in medicine that long, and yet he was that open-minded about this.
That's what it's about, because I think so. And so, do they need to have the obesity medicine certification? I'm not a real stickler for that. I mean, the obesity medicine certification's great to have, but honestly, the test materials are kind of the study materials. Andrea was making fun of it when I was studying for the board exam. It's very hypocritical, a lot of it, because it'll say, here's the science, but then we should still tell people to do X, Y, and Z that never was proven to work. And so it's very confusing. So I'm not a big stickler for that, but it might be a good area to find people who have a passion or,
at least they have an interest.
Time to go and get certified in the obesity medicine category. But I would definitely talk to your dietitian that you're working with that you trust about who they might recommend, because maybe they're used to working with certain physicians and they may have some good advice in that area. Having the good dietitian is great because, as you said, I mean, nutrition is really important, and there are certain things that can help with insulin resistance nutritionally. But as you said, also, it's not enough. That's the case in, 99% of the time. So and insulin resistance is actually a pretty easy thing to treat, and it can be reversible too. So aside from lifestyle, I mean, I'm not prescribing anything, but the most common medicine that's used to treat insulin resistance, if it's being shown in the fasting state as evidenced by high insulin levels relative to the glucose, metformin is just a simple med, and it's been around for almost 50 years.
And it's not expensive.
It's not expensive, it's not hard to get, and it's not usually controversial. So it could be something that you could even bring up if you're aware that even your insulin levels are high and your provider is kind of just continuing to talk about lifestyle only. You could suggest, well, what about metformin? Is that a good option for me? And they could look into your record and see if you might be a candidate for that, and maybe it would kind of spark their ideas and interest as well. But good luck finding someone. I am hoping to set up a network. So if any of our listeners have providers that might be interested, in what we're doing through the Diabetes Institute for provider training and building a provider community, that would be great to point them our way.
Yeah. info@diabesityiinstitute.org is how you can get a hold of Dr. Cooper. Jane, thanks a lot for that question. We have another question from the East Coast. This one's from Barbara in Westchester, New York. And she, too, was wondering about, if you had some people that you could refer to them on the East Coast. But Barbara says, I've been through countless providers who tell me just to diet and exercise more. She says, I clearly have a metabolic problem. I've been on more diets than I can possibly count. The first when I was 8 years old, and I'm 71 now. So she, too, was asking for advice in her area. But she also had a more specific question, Dr. Cooper, regarding GLPs. She says, I'm a survivor of tall cell papillary cancer. My thyroid was completely removed, and I had radioactive iodine. Would I be a person who could benefit from the GLPs, or would it be a problem due to the history? If so, why?
That's a great question, because there is concern over the GLP-1s have what's called a black box warning that a type of thyroid cancer, it's actually called medullary thyroid cancer, was detected in a strain of rodents, and it was long ago. It was actually with studies of Victoza, liraglutide, which was one of the first ones that came out. And so there's a warning because those rodents developed that medullary thyroid cancer at a higher rate. But since the years have gone by, that really has not been seen in humans at all. And these meds have been out now for almost 20 years. So there hasn't been a connection really in humans. But there never was a warning against taking the GLP-1s if you've had a history of papillary thyroid cancer. So for Barbara, the papillary thyroid cancer is not a contraindication at all to taking the GLP-1. You can still take GLP-1s if you've had that history. If you've had medullary thyroid cancer, or if your family members have had medullary thyroid cancer, there may be a genetic predisposition to that needs to be evaluated to determine whether you would be a candidate, but it's recommended generally against taking the GLP-1s if you have had personal history of medullary thyroid cancer or close family members. But
Okay.
Barbara, you're from our neighborhood. Andrea,
Yeah.
Andrea and I grew
We
up
grew
in
up.
Westchester.
Yeah.
What's Westchester like? I don't think
It's
I've ever been to
beautiful
Westchester.
and produces wonderful people.
Well, that makes three. Barbara, Andrea, and Dr. Cooper. I love it. So, Barbara, thanks for the question.
Moses says, good stuff. I'd love to hear more on how statins can lead to weight gain. Uh-oh, I take statins, I think. Uh-oh. Is that true? What's the story on that? I have a question, too.
This is a great question because I cannot tell you how much pushback we get from statin prescriptions. When we want to prescribe a statin, the first reaction from patients is, oh my gosh, a statin, I don't want to take a statin. That means I'll have to be on a statin forever. That's the worst possible medicine. But we really need to think about statins because they can be really life-saving medication. And it's not that everyone should take statins, first of all. There's some clear-cut guidelines as to who should take statins and which type of statins are indicated. But I did some more research because the last time I really did thorough look at the different statins and their side effects was probably, a few years ago. So I updated my knowledge a little bit because I've been getting so many questions. And it is true that statins can, as a group, in some patients, increase the risk of diabetes and prediabetes. So, of course, that's not good because we're prescribing them to people who already have metabolic syndrome, and so they're already at risk for prediabetes, but they happen to have these high cholesterol levels and maybe plaque in their arteries, where we do want to use something that's going to reduce the chances that they might have what's called a major adverse cardiovascular event. So we have to choose the statins carefully because there are several different ones. Some of them have been shown to have a higher risk of promoting prediabetes, and others have been shown to have a lower risk. And some of them have not shown any connection to any weight gain at all. And some of them have shown possible, but not conclusive, and pretty much cancels out the studies that show no weight gain, studies that show maybe weight gain, studies that show weight loss. So as a whole, the statins really do not cause weight gain, but the concern is that they could increase the risk of prediabetes or diabetes. And even some of the statins that we have preferred, because originally they showed lower risk of prediabetes and progression to prediabetes or diabetes, even some of those now in more recent studies are showing the opposite. So it's kind of like how you weigh all the research when you have half the studies saying that they reduce the risk of diabetes and half the studies say they promote prediabetes. So I think that it has to do with individual differences in a lot of cases. And so again, choosing a medicine based on that individual's overall risk is what's important. But I have an example of a patient I saw recently where this patient had extreme plaque in their coronary arteries. I mean, at a very high level, if you're familiar with calcium scoring, it was well over 1,000, the score. And so I had her on the most powerful statin that's been shown to have the best effect at preventing major adverse cardiovascular events in people with that level of plaque. And she happened to just read on the internet, or I'm not sure where she got the information, but she stopped taking it because she thought it wasn't good to be on a statin. Stopped taking it and started taking a supplement that was marketed for cholesterol. And the unfortunate thing is that when we got the labs back, she had reversed the diabetes to prediabetes, and then it was normal. And then it was going back to prediabetes, having been off the statin. So it was going back to prediabetes. The cholesterol particles were just through the roof. The risk was so much higher. And so I tried to explain that the supplements have not been clinically tested to see if they actually prevent these major adverse cardiovascular events or not. While the statins have, each and every one of them has a record. And so you can go in there knowing that if you take that statin, your risk is reduced by a certain percentage, where if you take a over-the-counter supplement, none of that applies. And so this is one case where someone who was afraid that it's going to promote diabetes went off it, and then the diabetes started coming back because they have different effects in different people. So I think carefully choosing which statin makes a lot of sense because they do affect different hormones like adiponectin, which is an anti-diabetic hormone. They can affect ghrelin, which is like an obesity hormone. But I don't think it matters that much to when you're picking the statin. I think if you go on a statin and then you observe, why is my A1C increasing? Or why are my cholesterol particles for LDL not improving? Those are the things that would say, well, maybe you should try a different statin and see how that does, as long as you're not at a risk for a major event if you don't stay on the most powerful one, if that makes sense. So you have to weigh these risks because it sometimes is worth taking the risk of a possible increase in risk of prediabetes or diabetes, but stopping a heart attack from happening, because there are medications that can treat the underlying metabolic dysfunction that's pulling you towards the prediabetes that can counteract any negatives that may be occurring from the statin. But also newer studies are showing that certain statins are associated with much lower risk of dementia. And this is important to say because the press has it the other way around. Patients are literally afraid to take statins because they think it's going to cause dementia, where all the new research is pointing to certain statins, like rosuvastatin, actually being associated with a marked reduction in dementia risk. So I think it's important to look at all of these things. Pitavastatin is one of the ones that is known to be associated with the lowest risk of progression to prediabetes or diabetes, so that's important to note. But it doesn't have the ability to prevent the major adverse cardiovascular events as well as something like rosuvastatin, which has mixed reports on the prediabetes and diabetes. So it's more complicated than we think. But the short answer, I was trying to give a short answer and I ended up with a long answer. But
well, it's complicated.
The short answer is that no for weight gain. But I just had to put in the other information about the statins because I think there's so much misinformation there.
Okay. Thanks, Moses, for the question. I think we have time for one more, Dr. Cooper. And this one is from Sue. She says, I have listened to nearly all of your podcasts while out walking and always come away informed and enlightened. I've also been a Cooper Clinic patient for the past 6 months. What a fascinating process. Very grateful for both! ! So Sue says, I've battled weight issues for 35 years since having my first child. I gained 40 pounds with my first pregnancy, 50 with my second, and have battled excess weight ever since. No gestational diabetes, nursed for a year. Is there something that happens metabolically in pregnancy that messes everything up? Some moms barely gain any weight, others gain a lot. So again, thank you for your important work, she says. That's from Sue. So what do you think, Dr. Cooper?
Well, thanks, Sue, for the question. It is fascinating that some people in pregnancy, some women, the pregnancy actually improves their metabolic function and they feel better metabolically throughout that pregnancy. And others, it's sort of like a fulcrum where the metabolic system just goes completely off balance. And so I do think that it has to do with the hormone balances going into pregnancy, the metabolic hormone balances. And during pregnancy, at the last trimester, ghrelin reduces quite a bit. So if that person went into pregnancy with high ghrelin, they will potentially metabolically benefit during the pregnancy. And the other thing is oxytocin goes up quite a bit during pregnancy, and oxytocin can be very beneficial if you have high agouti-related peptide, AGRP, which is a hunger signal in the brain. So some people going into pregnancy with high AGRP and high ghrelin end up with much better metabolic function during pregnancy, and they end up not gaining much weight. And also, those same patients tend to have problems with hypoglycemia, low blood sugar reactions, and their blood sugar's better also during pregnancy. They don't have the hypoglycemia as much because the oxytocin helps balance that. So anyway, it's interesting. I think that's the subset of people that do better in pregnancy. And the rest of women can really get flared up if they have genetics for diabetes or for gestational diabetes or for obesity, because it can trigger it, because it's almost like a growth phase and a lot of hormones start increasing during that period and they can end up overshooting, and you can end up with much higher insulin and growth hormone and all kinds of things that can start throwing the metabolism off.
Wow. So the short answer to the question of can pregnancy cause metabolic syndrome is the answer yes?
Well, if you develop gestational diabetes during pregnancy, it's known that that is a very high risk factor for developing full-blown diabetes and obesity post-pregnancy. So,
and that you can transfer it to...
And that you transfer it to the offspring, yes. Wow. So it is true that it can trigger that and then be the beginning of metabolic dysfunction that goes on for years. And then for women who have subsequent pregnancies, it can occur with each pregnancy. And so there can be that amplification.
So we're wrapping up our mailbag episode, and we love getting questions. And if you have a question, send it in. We love to hear you. It's info@diabesityyinstitute.org. info@diabesityyinstitute.org.
This has been so much fun. Send them in. And as Dr. Cooper said earlier, if you have a dynamite provider who's really into understanding metabolic issues, send us a note as well, because it would be great to develop that network of providers across the country that we can share with all of you, because I know that those of you who don't live in the state of Washington are kind of frustrated that you can't come see Dr. Cooper like we can. This has been fun. This has been amazing. We love to hear your questions. Send them in if you have them, and we'll have another mailbag episode very soon.
Ding dong, mail's here. Because it's ding dong, the mail's here.
I love it. I love it. So this has been another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.